Yeah, so that we just wanted to just recap some few important question which is asked by some of your girls, some of the girls in the class. So number one is about drug induced interstitial nephritis. So that we know when we say drug induced, so here the inflammation is occurring as a adverse reaction to the drugs. And this, what are the names of the drugs? So most important drug which is associated is penicillin, and the name of the penicillin can be methicillin and ampicillin. There can be other drugs which can be diuretic, they can be proton pump inhibitor, they can be non-steroidal anti-inflammatory drugs. So remember the name and the example of it. The question is, what is a pathogenesis? So pathogenesis, you see this picture and you can see how there are rashes. So it is a evidence of there is a hypersensitivity reaction which is going on. So this what will be the clinical evidence? You will see the patient clinically can have rash and the eosinophil levels can be increased. What is the main pathogenesis? So main pathogenesis, it can be type 1 hypersensitivity reaction or it can be type 4 hypersensitivity reaction. If it is type 1, so serum IgE level will be increased, and it can be type 4, the type 4 hypersensitivity reaction. They are T cell mediated, and like in this, if you will just see the what type of inflammatory cells are there, and the skin test, it will be positive. So what is the sequence of event it is happening here? So this drug, it act as a hapten or antigen. So when this drug is secreted by the tubule, it will bind with some of the component which of the cell. It may be cytoplasmic component or extracellular component, and then it becomes immunogenic or antigenic. And so whatever tubulointerstitial injury it has, it will result because of this antigen antibody reaction. So it can be caused by IgE or it can be caused by cell mediated immune reaction, right? So these are the injury. Because of this injury, the tubular cells or the basement membrane, it may get damaged. So this is a pathogenesis of drug induced interstitial nephritis, right? So remember, because it's always these are the hypersensitivity reaction, type 1 or type 4, and drug are acting as a haptens, right, and causing the antibody antigen reaction to take place. So what is the clinical course? So the clinical course is that after 15 days after the exposure of the drug, the patient may come to you with fever, the patient may have increased eosinophil, patient may have rash or the kidney problem. So if they are kidney problem, so in the urine you may see hematuria, right? Most common finding will be hematuria. So there may be little protein or WBC also passing in the urine. Passing of WBC is called as leukocyturia. And they say that the serum creatinine level may be increased, or there can be acute kidney injury. And when there is an acute kidney injury, the patient cannot pass urine, so that it is called as oliguria. You can see that 50% of the cases they can have oliguria in acute kidney injury. But the thing is, if you withdraw this drug, so this patient will recover, right? So this is starts after, maybe may start after 15 days. Patient have fever, eosinophilia, rash and renal abnormalities. If renal abnormalities in the urine, you may see hematuria. If there is acute kidney injury, the serum creatinine they will increase and patient may develop oliguria. If you will withdraw the offending agent, the patient may recover, right? So this was about the drug induced interstitial nephritis, right? Now there can be acute tubular injury. See, the tubules can be injured. These are the tubules, they can be injured. So what will happen? These tubules, they are lined by the epithelial cells. So these epithelial cells of the tubule, when they are damaged, so what will happen? So you know that proximal convoluted tubule, distal convoluted tubule, if they are damaged, so the renal function will have acute decline, and all these damaged cells, they will pass into the urine in the form of granular cast or in the form of tubular epithelial cells. Cast are like when they are collected epithelial cells, when they are passing in the form of cast, right? So this is it shows, whenever we use the word granular cast, it shows the damage to the tubular epithelial cells. And again, there can be acute kidney injury. So whenever the injury to the kidney is acute, the GFR will decrease, because functional unit of kidney, so it, like you know that these glomeruli, so they are the tuft of capillaries. So if the kidney is injured, so the glomeruli are damaged, so the glomerular filtration is decreased and serum creatinine level will increase. So these are the two investigation for acute kidney injury. And again, if there is acute kidney injury, we have again seen earlier also that if the kidney is injured acutely, patient will have oliguria. Oliguria means the urine output is less than 400 millimeter per day. Now this again is important, that this tubule can be injured because of two reasons: either ischemia or it can be nephrotoxic, right? Either loss of blood supply or there is some toxic injury, to the tubule. So ischemic acute tubular injury, right? So you have learnt in heart attack, stroke, whenever ischemia is whenever there is a inadequate blood supply to the kidney. So when the blood pressure is low, hypotension, when patient is in shock, so the ischemia can happen, the loss of blood supply can happen. So they can ask you what is the cause of ischemic acute tubular injury. Means ischemia means loss of blood supply. So one is hypotension, shock. So you know that it can happen in severe trauma, blood loss, acute pancreatitis, septicemia, or mismatched blood transfusion. So whenever there is when you give a mismatched blood transfusion, so these patients can have hemolytic crisis. So you will see the myoglobin which is present in the muscle, it will also start passing in the urine. So it will be, so you can know that this patient may be having ischemic tubular injury, right? This is about the ischemic tubular injury. Now if somebody asks you nephrotoxic acute tubular injury, so what are the toxicity? So it's like very important, right? Nephrotoxic, so it is caused by poisons, mainly, like it is caused by variety of poison. They can be heavy metals like mercury, they can be organic solvents like carbon tetrachloride, they can be drugs like gentamicin, they can be radiographic contrast agents. So please don't forget, ischemic acute tubular injury means kidney tubules are getting injured acutely, either because of ischemia, loss of blood supply, or because of nephrotoxicity. So if it is because of nephrotoxicity, it can be, so this, remember these, right? So metals, heavy metals, organic solvents, remember the name: mercury, carbon tetrachloride, strong drugs like gentamicin, radiographic contrast agent, right? Please remember this. So what is a pathogenesis? So they say that these are the, you know that kidney is made up of tubules. So proximal tubules, they are very, very sensitive to hypoxemia, loss of blood supply, or to the toxins. So whenever there is loss of blood supply, epithelial cells, they will be damaged, their structure will be altered, the cell polarity will be lost. So whenever the polarity of cell membrane is lost, so the sodium potassium ATPase pump, right? So this pump, it will be redistributed, and this pump is present on the basolateral surface, and from this basolateral surface, this pump will shift to the luminal surface. So whenever it is shift happens, so the sodium will not be reabsorbed by the proximal distal tubule, and this sodium, the more sodium will come to the distal tubule, because proximal tubules are not absorbing it. So all this extra sodium is coming to the distal tubule. Why proximal tubules are not absorbing it? Because there is a loss of polarity. The sodium potassium ATPase pump, these are all proteins pump present on the membrane. They have got redistributed. Their position is changed. From basolateral, they have come to the luminar surface of the tubules. So therefore, because there was hypoxia or toxin, so this shift redistribution happen in the sodium potassium ATPase pump. So when the pump is not working, sodium is not reabsorbed, and it is just going to the distal tubules, right? So if we see here, so they say when the more sodium will come to the distal tubule, so what will happen? So there will be a tubuloglomerular feedback system. So whenever there is a more sodium which is coming to the distal tubule, so the arterioles will constrict and the glomerular filtration rate will decrease, right? Because this is because the more sodium is going there. They don't want more sodium filtration to happen. So because of that feedback mechanism, arteriole vasoconstriction will happen, and So what will happen? Now the glomerular filtration rate is decreased, arterioles are constricted, so there is an injury to the epithelial cells. So whenever the injury to the epithelial cells is there, these cells will detach and they will shed into the urine. And they say these the debris, the damaged epithelial cells, they can just build up in the lumen of the tubules and they can block the outflow of the urine. So they are just causing the obstruction. This obstruction is by the cast. Cast is the tubular debris, and sometimes there is a increase pressure in there is an increase intratubular pressure, so GFR is more decreased. So if we just try to understand this, so the because of the redistribution of sodium potassium pump, so the more sodium is coming to the distal tubule, which is causing the increased arterial vasoconstriction. So the glomerular filtration rate is more decreased. As it is decreased, so the epithelial cells, they are detached, they are shed, and they will block the outflow of the urine. They are just these damaged tubular cell, they will make the cast, and these tubular debris and cast, they will block the outflow of the urine, and they may make more pressure inside the tubule. Intratubular pressure will increase and the GFR will more decrease, right? So the kidney is getting more damage. So if we see, so these now the tubules, they are damaged, so the whatever fluid was there, whatever urine was there, it will come into the interstitium. So the interstitial pressure will increase, more tubules, they will the tubules in the interstitium, because of increased pressure, they will collapse and urine output will decrease, more it will decrease, right? And they say when the tubule cells, these ischemic tubular cells, so they will also express the cytokines, adhesion molecule. So we learned in the inflammatory lectures in second year. So whenever the more cytokines are secreted, more adhesion molecules are secreted, so more leukocytes will come and they just participate in the interstitial inflammation, right? So if we see here, so they say that the tubular injury, it is more aggravated whenever there are these type of hemodynamic alterations are going on. More sodium is coming to the distal tubule, causing more epithelial, causing arteriolar vasoconstriction, causing more tubule damage, causing that tubular cast to block the urine output, which is reducing the GFR, right? So the more major one among this, whenever the tubules are injured, so the most major problem is because there is a intrarenal vasoconstriction, right? So whenever there is a vasoconstriction, so what happens is that glomerular filtration rate, the plasma flow in the glomeruli, it is reduced. So the oxygen supply to the tubules is reduced, right? And they say, so if we see that there is a reduced oxygen delivery to the ascending limb and to the proximal tubule, right? And they say that so what happens here is the vasoconstriction. Why this vasoconstriction is happening? Because there is a endothelial injury which is going on, and when the endothelial injury is going on, so they will release the endothelial vasoconstrictor endothelin, and there will be decrease nitric oxide and prostaglandin. So these are the changes which are happening, which is causing vasoconstriction. And they say that sometimes there is a direct effect of ischemia and toxin, so on the glomeruli, so therefore there is a decreased glomerular filtration rate, right? In these cases, you will see that tubules are getting necrosed, so there is a patchy necrosis which is going on, right? So they say that this is all about the pathogenesis. So if we see this diagram, we can understand more. Now you can just see this diagram. So this is your efferent arteriole and this is your afferent arteriole. There is a ischemia which is happening. Because of the ischemia, loss of blood supply, these arterioles, they are undergoing vasoconstriction, right? And there is a tubulo-glomerular feedback which is going on. These are the tubulo feedback which will start as soon as these arterioles, they will constrict. So when these arterioles are constricted, there is ischemia, loss of blood supply, the glomerular filtration rate here it is decreased. So here it is, so whether it is ischemia or it is toxic injury, so they are causing the epithelial cells of the proximal tubule, they are injured. So here you can see they are injured. The sodium absorption is decreased here in the proximal tubule, and this more of this sodium, it will go to the distal tubule, and when the more sodium is reaching in the distal tubule, the more sodium has come here because it is not absorbed here. So this more sodium which has come here, it will give tubuloglomerular feedback mechanism. So it will tell the arterioles to constrict. So there will be a vasoconstriction. So you understand. So the main problem which has happened here is the ischemia and toxic injury. So they have caused the redistribution in the sodium potassium pump. So the sodium absorption is decreased in the proximal tubule. So more sodium is coming to the distal tubule. When more sodium is here, so this tubule are giving the feedback mechanism to the tubuloglomerular mechanism, and because of this, the vessels they are constricting, right? So you see then this is a tubuloglomerular feedback mechanism which is going on. So it will give the feedback, and these arterioles they will constrict. So you see the more glomerular filtration rate, it will decrease. When when GFR is decreased, so it means like glomeruli are not filtering the plasma, so there is a decreased urine output. So these patients, they will have oliguria, right? And if you see here, when these epithelial cells, they are damaged, they are detached, they are being shed into the urine, so they are just blocking, they are causing the obstruction in the tubules, and whatever fluid was present here, it is coming into the interstitium, and it is increasing the pressure in the interstitium. And you can see, so when the pressure is increased, so these tubules, they will be obstructed more, right? So again, so you can just, with this diagram, the last 4-5 slides that we have listened, so sometimes it is difficult to understand. Look at this diagram again and again and try to revise the previous slides, right? And this is your pathology part. So whenever the tubules, now you see these are the tubules. If you see in the diagram, these are the tubules which are injured. So they are detached cells, and these cells, if you can see these cells, they are having granular cast. In the lumen, there is a pink thing. These are called as granular cast. These are the damaged epithelial cells, right? We call them as granular cast. Or you can also see the necrotic tubular epithelial cells. These are all cell debris, granular cast here. And this red thing which you see, these are the congested capillaries which we see, right? So what is the clinical course of it? So there is oliguria. Now you understand why the urine output is decreased. So there is decreased glomerular filtration rate. Because of that, there is decreased urine output, and we call this decreased urine output as oliguria. So these patients, so they can have anuria also, means they will not be able to pass the urine, right? So sometimes there may not be any problem with passing of urine if the injury is mild. There can be electrolyte abnormalities. You have just seen how the sodium like absorption, it can be decreased, and how the more sodium reaches distal tubule. So electrolyte abnormalities. There can be acidosis. The patient can present to you with the symptom of uremia. So urea level may increase. There can be fluid overload, right? And when the cause of acute tubular injury, acute kidney injury is acute tubular injury, because the kidney can be injured acutely. When the kidney is injured, kidney has glomeruli as well as tubule, but when the cause is because of the acute injury to the tubules, right? So sometimes they say that when the repair may start, the tubule may regenerate and the clinical improvement may occur. But if there is no supportive treatment, no dialysis is given, the patient may die, right? And these acute tubular injury, it can even, like if it persists or if it recur, it can change into chronic kidney disease. So I hope now it's easy, you understand it, right? So if any point you don't understand, you can just ask me again, okay? Okay, salam to all of you.